developmental, you have two types, no? Let's go to the prevalence first. So the prevalence of the disease from various studies is from 0.1% in some studies to 0.022%, not 0.06%, but it is fairly common. It is not a very rare disorder, and we usually see it in a lot of patients in our practice. So let us look at the classification now. Something has happened to the fonts, please excuse me. And if there is a clinically apparent telangiectasis in the perifoveal region, it is then divided into type 1, type 2 and type 3. The type 1 is unilateral perifoveal telangiectasis. It is also called aneurysmal telangiectasia. It is unilateral, male predominance is there, youngsters more often, and it will have a succinate exudate or sometimes a Legan exudate plaque. In type 2 or the juxtafoveolar telangiectasia as it is called is the most common subtype that we see. It is bilateral, male and female is the same. Onset is for 40s to 60s. It has a strong association with diabetes and hypertension. In this you will see the foveal cavitations and the crystalline retinal deposits, which we will come into later. Type 3 is very rare, and it is bilateral, again equal male and female. There is occlusion of the perifoveal capillaries. It is progressive with significant visual loss compared to type 1 and type 2. Staging is stage 1 is only occult telangiectatic vessels that is not clinically visible. In stage 2 there is loss of transparency of the retina in that area, but again clinically vessels are not visible. In stage 3 there is a prominent dilated right angle retinal venule. Stage 4 there is retinal pigment hyperplasia into the retina, and stage 5 there is subretinal neovascularization from proliferation of the intraretinal capillaries, which then proceed downwards. Now symptoms: blurred vision, metamorphopsia, difficulty in reading. Many of the patients will complain that when they are seeing, some of the letters are missing in the words that they are seeing. That is a very common complaint that they say. And sometimes you may diagnose it before it actually causes any symptoms at all. On fundus examination, the first sign that you will find is a subtle loss of retinal transparency in the perifoveal region. This becomes more pronounced over time. Now we can look at that in detail. There is loss of retinal. See the picture, you can see the refractive. Please do. Crystalline dots can be identified at the vitreoretinal interface with associated perifoveal graying and loss of retinal transparency. Then you can see the right-angled vessel. Right-angled retinal vessel you can see, that is blunted arterioles or venules that connect to the superficial and deep plexus, and they may be difficult to appreciate without stereoscopy. Next, that right-angled vessel will be surrounded by retinal pigment epithelial hyperplasia, and later on you may get very rarely subretinal neovascularization with intra and subretinal hemorrhage, which are features of the neovascular stage of Mactel. Fluorescein angiogram in the neovascular stage will show you similar to your neovascular AMD, a neovascular network. Next one. Yeah. Then later on, once the neovascular stage is over, you can get fibrovascular scarring also, similar to what you get in age-related macular degeneration. But you should remember that there will be absence of drusen, and that hyperplasia of the retinal pigment epithelium will be there. Fundus autofluorescence is one of our important tools that we can use to identify early AF, early Mactel, because on blue light FAF, because of depletion of the macular pigment, you can see the hypofluorescent area even in the absence of any fluorescent leakage on FFA. So there is loss of the luteal pigment that causes the hypofluorescence on FAF. Fluorescent angiography is again probably the most clinching diagnostic thing. You can see the characteristic telangiectatic capillaries, and you can see the deeper system being involved as well as the superficial capillaries. There is late staining, late leakage and staining in the perifoveal area, and that is the early angiographic feature of Mactel. OCT, the most subtle and the earliest change that is associated with Mactel is a temporal enlargement of the foveal pit, resulting in an asymmetric pit with disparate temporal versus nasal thinning. One of the more common ways we can see is the identification of cavitations in the OCT. On follow-up, these cavitations can change in size. Cavitations involving the outer portions may resolve, while the larger areas will be left where the ellipsoid zone is absent. And sometimes outer layer cavitations don't close, but the ILM under the ILM they may close. Later, the entire area becomes thinned out, and there is only a thin ILM that is stretching across the cavitations called the ILM drape sign. And in later on, they can have a partial or full thickness macula hole-like appearance. This is a progression that you can see. Here you can see the cavitations beginning. As the follow-up increases, you can see the cavitation involving both the layers, and finally there is only an ILM drape there. So the loss of this is supposed to be due to the known loss of Muller cells and photoreceptors. With loss of the outer retinal thickness, the middle layers of the retina sinks, and this is called retinal subsidence. Now, OCT angiography is also one of the newer tools. Without invasive fluorescent angiogram, we can actually detect this network very easily. You can see the right-angled vessel, as well as you can see the dilated and telangiectatic vessels in the capillary plexus. There is an autosomal dominant pattern of inheritance, and the ataxia telangiectasia muted gene ATM is also been implicated in the pathogenesis of mactal type 2, and some of the other loci that are implicated are 2q34 and 1p12, which have been implicated in the glycine or serine metabolic pathway. The differential diagnosis, of course, it may be like we may think of it as an old TVO, sometimes radiation retinopathy. When it's in the stage 5, you may mistake it for a choroidal neovascular membrane. What can you do? You can explain the prognosis and observe up to stage 4, and only in stage 5 do we need treatment with anti-VEGF. There is no point in injecting thinking that it is a macular edema. Those foveal changes that you're seeing are actually loss of tissue, so you cannot treat it with anti-VEGF agents. You can do visual rehabilitation because they need reading, so you can give low vision aids. Antioxidants we all prescribe, but there is no proven benefit. There is an ongoing study with ciliary neurotropic factor, which they have found has some favorable effect, and there are phase 2 studies going for a CNTF implant in mactal type 2. So that's all about mactal from me. Thank you all for your patience.
Thank you very much. One or two leaking, if there are aneurysms specifically type 1.
We do see in the perifoveal network. I have not attempted it. It is perilously close to the foveal neovascular.